Dear ladies and gentlemen, and dear Chairman, Mrs. Chairman, I'd like to thank you for the invitation to International Hospital of Bahrain and Bahrain for my second visit, especially Dr. Mrs. Sira, because it's been a pleasure to be here. Last time see patients, and today I have the privilege to give a talk on a topic that is not my main daily bread and butter. It's about metabolic consequences of what I do every day, the gastrointestinal disease. And after Dr. Badawi, Professor Badawi gave a nice talk on GI sources of osteoporosis, this will add on to it, I hope. So first I want to tell you a little bit about nutrient absorption in the small bowel, this is a busy slide, but it will show you that the GI tract is really important for a number of issues, in the absorption of nutrients and vitamins in the GI tract. We can start in the antrum. You will see intrinsic factors produced there, so if the antrum is removed or doesn't function, then this will be reduced and the vitamin B12 absorption will be low. The duodenum, we find primarily iron absorption and absorption of calcium, active absorption here, as well as lipid digestion. The jejunum is important for folate absorption and passive calcium absorption. And finally, the terminal ileum, for the gastroenterologist, a very important area, will also be important for vitamin B12 absorption once it's hooked up to intrinsic factor. So disease location and cofactors are essential for adequate nutrient absorption in the bowel. Let's start with a case presentation to illustrate that. This is a 73-year-old man I saw. He has a long-standing history of celiac disease, and he presented to me with diffuse bone pain, primarily in the lumbar spine and hips. He ached everywhere in the entire body, and this became debilitating a few months prior to his visit, and he couldn't even turn in bed. On the endoscopy table, he was screaming in pain and couldn't be mobilized. The patient could hardly rise from a chair, and he used a walking stick for ambulation. He had mild dietary indiscretion with his gluten-free diet, and he had about 5 semi-formed bowel movements a day, and he used NSAIDs for his pain, but not with a lot of relief. His laboratory was interesting and shows a lot of abnormalities important for this case. He has a hemoglobin that's low. Surprisingly, it's a macrocytic anemia. Usually we see microcytic anemia due to iron deficiency in patients with celiac disease because celiac disease involves the duodenum. He had a very high alkaline phosphatase, which was almost all bone alkali phosphatase, and low calcium and phosphate. He also had 25 hydroxyvitamin D that was almost not detectable. The 125 hydroxyvitamin D was detectable, and then the PTH was not surprisingly very high due to secondary hyperparathyroidism. He also had a tissue transglutaminase antibody, which was high, which shows that he does not adhere to his diet very well and that he has inflammatory activity due to his celiac disease. This is a typical picture of what I do every day and of this patient, an endoscopy of the upper intestine. And you can see typical scalloping of the mucosa, which is due to the atrophy from celiac disease. And this is his CT scan, and what I'd like to point out is here this pseudo-fracture in this area. I'll talk about this later. This corresponded to increased activity on the bone scan. This is the patient. He allowed me kindly to shoot a video of him and show it. You can see he can hardly walk. He goes very slowly. He has a waddling gait, and he also uses a walking stick. And I'll come back to this patient later at the end of my talk. So celiac disease has a lot of nutritional aspects I'll talk about right now. This patient suffered from osteomalacia, and the typical features are almost all present in this patient. We talked about this briefly beforehand. He has low vitamin D levels first and foremost, and those are responsible, as we heard earlier already, for the extreme bone pain. Why is that? Because mineralized bone is decreased and osteoid increased. The bone gets demineralized and puts a lot of tension on the periosteum, which is extremely painful. The alkaline phosphatase is elevated. The low calcium and phosphate levels are typical, and there's decreased bone density. And these findings that we found are actually classic findings of Looser's zones, pseudofractures in the bone that occur with osteomalacia, probably in the area of vessels that are near the bone. And patients typically have bowed long bones. You could see that on my presentation. And they also have a so-called Waddling Gait, which was very, very well seen on this video. A recent publication shows that this can not only occur in adults, but also in children. And with them, the problem is in the epiphyseal plate during growth, and they can get thickening of their joints here or valgus deformities. So 3 factors are important for the mechanisms for developing bone loss in celiac disease. One is the inflammatory or immune-related reasons. Others are impaired absorption, and finally dietary reasons. Let's talk about this briefly. First, we talk about the inflammatory problems, and we can see that inflammatory cytokines, as we heard, are important in any type of inflammatory disease, also in the gut, and they will increase osteoclast activity in some patients. There's also neutralizing autoantibodies against so-called OPG, which stands for osteoprotegerin. That's a protective factor that inhibits osteoclast activity. If you have antibodies against it, I'll talk about a little bit later again, then you will have increased bone loss. And this OPG counteracts RANKL. RANKL is a receptor-activated NF-kappa B ligand, and the receptor-activated NF-kappa B together will act to increase osteoclast activity and bone absorption. And if you have high RANKL and low OPG, your bone will get lost. So we talk about absorption in celiac disease. As I showed you, the mucosa is atrophied, and this will lead to decreased calcium vitamin D absorption. And dietary factors are important too, because our diet is low in vitamin D and calcium, as we heard, but these patients are particularly prone to this because they take gluten-free diet, which is especially low in these factors. All of these factors lead to hypocalcemia, increased parathyroid hormone, and even more bone loss, which causes osteoporosis or osteomalacia, in this case due to vitamin D deficiency. So what happens to calcium in the gut? How do we absorb it, and where do we absorb it? So first, the most important area of absorption is here the active absorption in the duodenum, and that's vitamin D dependent. The second most important one is passive absorption in the jejunum, which might not be quite as important for overall calcium levels. So you can see celiac disease is located in the duodenum. It will affect calcium increase. It will also affect the receptors of vitamin D in the gut, because if you have atrophy, those are gone too, and decreased vitamin D absorption. This is a busy slide, and I will not and cannot bring you through all these factors that are involved in vitamin D maintenance, but I want to point out a couple of things. We heard about this earlier. People in our part of the world sometimes where celiac disease is more common, they don't get a lot of sun exposure. They also develop secondary hyperparathyroidism because of the mechanisms that I mentioned earlier. They have poor absorption, those celiac patients, and one thing that we do not keep in mind, they also have diminished enterohepatic circulation of vitamins, so these factors all contribute to the bone disease in these patients. And a recent publication in the New England Journal of Medicine shows that these OPG antibodies that I mentioned earlier play a role or may play a role. You can see here, this is a positive control for the antibody, which is at approximately at 60 kD. And you can also see that normal patients do not have this antibody. Patients with hypothyroidism also do not have this, but patients with celiac disease, they do have bands in this area suggesting that they have the antibody, and it may play a pathophysiologic role. So what happens to bone density in those patients with celiac disease? It goes, not surprisingly, it goes down, and especially in men, much more so than in pre- and postmenopausal women. Why is this? We don't pay much attention to men in osteoporosis, not as much as we should, especially in GI disease. We need to keep an eye on this. There's also risk of fracture in celiac disease, and this is interesting because this tells us again that men are kind of not paid attention to in this disease. You can see here that males have, in contrast to females, have more risk of fracture as compared to controls before they're diagnosed with celiac disease. And this will stop after the diagnosis is made and the patients are adequately treated. So we need to pick up those patients, and we need to think about treatment early on, especially in men. But celiac disease can also cause other nutritional defects, especially iron absorption problems. And this is, as I mentioned earlier, the most common finding is an iron deficiency microcytic anemia in these patients, and everybody who has unexplained microcytic anemia should be screened for celiac disease. And this, you may think, well, celiac disease is more of a problem in my part of the world. It's not only there. This is a publication here recently from Iran, which shows that you also need to think about this in areas of suspected rare prevalence because it happens. So let's talk about IBD briefly. We also touched on this. The prototype disease in inflammatory bowel disease that causes nutritional deficiencies and absorption problems is Crohn's disease, because it can affect the whole gut from the mouth to the anus, and therefore all kinds of absorptive problems. And colitis can also be involved at sometimes in nutritional aspects, but not as much. In the stomach, Crohn's disease is rare, so it really doesn't affect it too much, but the duodenum, it can cause calcium and iron resorption problems. In the jejunum, as I mentioned, the folate is absorbed, leading to possible microcytic aspects of the anemia and the calcium deficiency. And this is number one in Crohn's disease, is the vitamin B12 absorption in terminal ileum, where it's present most of the time, is decreased, and a lot of those patients need parenteral vitamin D supplementation. And we talked about vitamin D and vitamin K also as factors for osteoporosis, and all of these are not well absorbed in patients who have disease in the ileum. So remember that and check for these problems in your patients with IBD. And this slide is kind of adding on to what we heard already, that IBD has not only risk for osteoporosis because of the malabsorptive problems, but also because of the use of corticosteroids, the low BMI in patients with poor nutrition and IBD, and a lot of sick patients also are immobilized, so all these factors will contribute. And just to point this out, the Rankel OPG system that I mentioned earlier in celiac patients also plays a role in IBD, and I'm sure we will hear more about that in the near future. So what are the screening recommendations of my association, the American Gastroenterology Association, or our association on this. It's how should we screen patients with IBD? Well, if any of this is present, prolonged steroid use or low trauma fracture, we talked about this, postmenopausal patients or patients who have hypogonadism, do a DEXA scan. If you have a celiac patient, this is interesting and something I haven't followed yet, I have to admit, is that all adults who are on treat or who have celiac disease and are treated for at least 1 year should be screened with the DEXA. I think we, in practice, this is not done as frequently. And then post-gastrectomy patients, I will talk about later in the last part of my talk. So if they have a T-score that is greater than -1, the patients who are beginning to become osteopenic, they should be substituted with calcium, vitamin D. They should have regular exercise, stop smoking, watch their steroid intake, and so on. And if they become more osteopenic in this range just before they're fully osteoporotic, there we should do the same measures and add a DEXA scan every 2 years. And if they're on steroids for a prolonged period of time, then we also should consider putting them on a bisphosphonate. And finally, the osteoporotic patients, you do all of the above, and you refer them to a specialist, and the GI doctors probably should get help from outside then as well. So what are barriers to using this? Well, one I already mentioned is maybe the knowledge about these guidelines or time and cost, but other factors that hinder this is that we focus on one thing and not the other, and we think the other doctor may take care of these issues and it might not happen. So everybody involved needs to be aware of these guidelines and also aware of the things that do not or are not everyday practice for them. So let's talk about my next part, the medications that can affect absorption. Here, especially one medication I want to mention that is given almost as if it was candy in our part of the world at least, and probably here as well, that's proton pump inhibitors. Proton pump inhibitors have been shown to increase risks of hip fractures in osteoporosis. And this meta-analysis that's published recently in the American Journal of Gastroenterology shows nicely that this is pretty much stable in most of the studies available. What are the mechanisms? We really don't know. Acid suppression impairs intestinal calcium absorption. That may be one problem. The other thing is that the proton pump that is inhibited is similar to the HK ATPase of the osteoclasts, and this could increase fracture risk. And finally, as I mentioned, because we're not quite sure if the PPI are directly responsible for the increased fracture risk, or if this is a finding that is led through another form of a mechanism, we shouldn't stop PPI automatically. We should give them, but be aware of it and check for the osteoporosis and if it's treated well. This is something that was mentioned earlier in a number of talks, the L-thyroxine treatment, and also this is affected by PPI use, something that gastroenterologists at least might not be as aware of as endocrinologists. And in this study, they did a retrospective study where they looked at what happened to people who were under treatment with L-thyroxine and when you added a PPI. And what they found is that the TSH changes, so there is an effect on absorption. So what the authors recommended to do is once you're stable on LT4 treatment and you add a PPI, do another TSH testing, it's probably worthwhile. L-thyroxine is malabsorbed easily by a number of factors, and a lot of them involve the GI tract. One of it is food, fiber, and coffee in our coffee break here, and others are all kinds of intestinal diseases, obviously. And finally, we give a lot of drugs in GI medicine that affect absorption, such as cholestyramine, ferrous sulfate, or PPI, as I mentioned. So the final part of my talk will briefly touch on surgery and absorption, and I was asked not to go into too much detail. I think you had a talk or a conference on this last year. So what I briefly will just want to get over to you is that depending on what part of the gut is removed, you will have certain deficiencies, obviously. And if you might not be able to counteract those deficiencies by oral means, because absorption just cannot happen this way. And what I mean is that, for example, if you resect the antrum, intrinsic factor is missing and vitamin B12 absorption will be worse, acid might be missing, and calcium absorption may be worse. And if you have a Billroth 2 situation where this part is kind of in a blind loop and not directly in the nutritional stream here, you will not absorb iron and calcium as much either. So be aware of this when you have patients with surgery of this kind. And the most, or probably even more common in this area than with my patients, are all kinds of bariatric surgeries that do involve these aspects as well. And just keep in mind that every bariatric surgery that has some form of a bypass of the stomach and the upper intestine will cause deficiencies, and those need to be treated, and oftentimes also in a parenteral way. So in summary, patients with celiac disease are at risk for osteoporosis and osteomalacia, or the combination of it, as we heard, and iron deficiency may also be a problem and should be screened. Patients with IBD, and especially Crohn's disease, are at risk for osteoporosis, and especially should be screened for concomitant risk factors such as steroid treatment. PPI probably increase the risk of osteoporosis-related fractures, and they affect L-thyroxine absorption. And finally, bariatric surgery frequently affects vitamin and mineral absorption and might require parenteral substitution. Now, before I end, I want to show you my patient one more time. You see the pain in his face, and you can see his waddling gait once again. After 3 months, he walked without any pain, and he was doing much better. And thank you very much for your attention. There you go. Okay, now I hope you believe me that he did it a little bit better. He didn't need the walking stick either anymore. And he had a little smile on his face at least.